Hello, my name is Paul Friedman. I'm chair of the Department of Cardiovascular Medicine in Rochester, Minnesota at the Mayo Clinic. And I'm delighted to have with me today my colleague, Adrian da Silva, who is a senior associate consultant and expert in heart failure with a special interest on the implications of obesity and heart failure. Adrian, thank you for joining me.
Thank you very much. It's a pleasure for me to be here talking with you about this topic that I'm certainly very passionate about.
Well, it's an interesting one. So the first question is, does obesity increase the risk of heart failure?
Well, yes. The short answer is yes, and significantly, which is very unfortunate, especially if we take into account the high prevalence of obesity that we have in the adult population in the US, which over the past 5 years has exceeded 40% of our adult population. So you can imagine that there is already a huge overlap here. Now, the obesity is not just a risk factor for heart failure alone. It's a risk factor also for many other cardiovascular diseases, as you see in your clinical practice, and which are per se additional risk factors for heart failure. Now, many studies have addressed this question. And Framingham Heart Study even found that by each 1 point increase in BMI, there is actually an increase of 5% in the risk for men to suffer heart failure and 7% in women. And the worst thing is that this was observed throughout the whole spectrum of BMI. So, as you can imagine, then this means that these increases are, well, more dramatic amongst those patients with heart failure with preserved ejection fraction, which has slowly become the most prevalent type in the US.
Now, just for people to review, normal BMI numbers, low BMI, overweight, obese, remind everyone of those ranges?
Well, there is some granularity about that, which unfortunately we don't usually pay attention to, and we should. For Europeans, meaning Caucasians, the normal BMI is between 18.5 and less than 25. From 25 to less than 30 is overweight, and 30 and above is obesity. Now, for Asians and Pacific Islander descendants, it's much lower. The normal BMI for them is less than 23. And between 23 and 25, it's already overweight. And from 25 onwards, it's obesity. The big problem here is that most of the studies do not account for that. Even when we look at the statistics of the CDC, they just define obesity by the European standards, which does not recognize the high metabolic and cardiovascular risks that these patients of Asian and Pacific ancestry may have.
Now, just one more question about obesity and the risk, and that is, you've really very clearly outlined the markedly elevated risks of both heart failure with reduced ejection fraction, and particularly HFpEF in the context of obesity. But as you pointed out, obesity is associated with diabetes, hypertension, sleep apnea, multiple other risk factors. Is the obesity a risk factor independent of those, or is it simply helping generate those conditions which in turn lead to heart failure? Or is it no?
Overall, we already know that obesity certainly increases some risk, the risk of some cardiovascular factors that predispose to heart failure and many other conditions. Additionally, obesity per se is a pro-inflammatory disease, which has additional implications in of itself, which confers cardiovascular risk. So it's most likely multifactorial what we're dealing with here.
Got it. Now, do patients with obesity and heart failure have worse outcomes than patients without obesity and heart failure?
Well, this has been a very important question that we have been addressing since the early 2000s. So there was this landmark study conducted by Dr. Horwich out of UCLA, and they analyzed the survival of patients with heart failure and different BMI groups, normal weight, overweight, and obesity. When they just analyzed the actual survival rates, they didn't notice significant difference. Nevertheless, when they accounted for important predictive factors such as sex, age, hypertension, diabetes, ejection fraction, peak VO2, they noticed that the BMI category per se was an important factor associated with survival during follow-up after heart failure diagnosis. Meaning, and this was the most surprising thing at that point, they noticed that those patients with overweight and obesity, especially the lower classes of obesity, had better survivals over time than those that had normal weight and those that were underweight. Overall, those patients who are on the lowest weights, meaning less than 18.5, or those who are cachectic, tend to have the worst outcomes across the studies. Now, this, as you can imagine, this led to some controversy, and some people started wondering, well, should we try to address obesity in these patients if they seem to be surviving longer according to their overweight or obesity status? And well, the issue was that in those initial studies, it was difficult to assess whether the patients had lower weights because they were cachectic due to the severity of their disease, or if they were actually intentionally losing weight. So, but that's...
Is it an answered question, or do you say it's still not known? That is, do we want to help patients with obesity and heart failure lose weight? And if so, how do we treat them?
Certainly. We at this point we already know that obesity, although it tends to be associated with better survival after the diagnosis of heart failure, we know that obesity is a huge risk factor for heart failure and other cardiovascular conditions. So these patients actually benefit from intentional weight loss. And this is something that we see in our clinical practice every day. Patients with heart failure or other cardiovascular conditions receiving weight loss interventions, whether dietary or more remarkably bariatric surgery. And then they experience significant improvement, not just in their quality of life, but even some large observational studies, some registry studies, have found that amongst patients with heart failure and obesity, bariatric surgery is associated with a decrease of 50 to about 75% decrease in mortality at 4.5, 5-year follow-up.
That's stunning. In general, do we treat patients with obesity and heart failure the same way as we would treat obese patients without heart failure, or is the obesity therapy modified?
This is very important to keep in mind. Well, we already know that these patients benefit from these interventions, but we also know that due to the nature of their heart failure, they are at higher risk for procedures and surgeries. So unfortunately, there is not an easy fix, but these patients benefit from losing weight and from doing so in a very specialized center with experienced surgeons and experienced multidisciplinary team with close collaboration with their heart failure cardiologist. Many studies have already found out that not just their survival is improved, but other comorbidities are also improved after significant weight loss. Mortality and other complications may be higher than other patients without heart failure after surgeries like bariatric surgery. But overall, we notice that in the long term, their survival is better, and also they tend to experience objective improvement in their myocardial parameters. We know from studies of Dr. Barry Borlaug from here at Mayo Rochester and other investigators elsewhere that there is significant improvement, significant reverse remodeling in many parameters of the myocardium after significant weight loss, especially after bariatric surgery. In some cases, these patients even benefit, even experience significant improvement of the left ventricular ejection fraction after surgery. Now, some patients have even achieved remission of their heart failure, granted that a minority. But we tend to see in our practice that these patients, as they lose weight, they require less diuretics, they feel better, their fitness improves, and some of them actually end up needing less cardiovascular medications.
That's remarkable, and certainly the literature for bariatric surgery has been clear. There's less atrial fibrillation, less sleep apnea, less hypertension, less diabetes, and now, as you just explained, less heart failure. What about pharmacologic therapy for obesity? Any comments? Clearly, tirzepatide and other medications are having a huge impact. Is there a role for these in heart failure patients?
Well, that's certainly a very exciting point. We have been using those in patients with heart failure. There was a signal in one study with a different medication towards potential worse outcomes several years ago, but in current practice, we know that these patients actually benefit from receiving these highly effective anti-obesity medications. Now, there are going to be some trials that are going to educate us more on that. But these patients, I think, definitely benefit from them. Now, this is an observational statement, and this is something that also some of my colleagues have noticed and think. Something else that we need to keep in mind whenever we talk about weight loss management in patients with heart failure is not just on the usual heart failure weight loss strategies, but also we need to be mindful of what we do to treat the heart failure per se. We know that there are medications that can induce some weight gain, such as metoprolol, whereas other ones may be more weight neutral, such as carvedilol, which may be a better alternative in these patients who may actually have higher blood pressure compared to their counterparts. And even other medications that we use routinely, such as the SGLT2 inhibitors, may help lose some weight. Now, not a remarkable amount, we're talking about a couple of pounds, but little things can make a difference over the long term. And I think that some of us have noticed how our patients may start gaining extra weight after we maximize them on their metoprolol. Now, I'm not saying not to treat them with GDMT. Of course, we need to treat them, but we need to be mindful about these things.
Last question for you. Can patients with obesity and end-stage heart failure receive heart transplants?
Well, that's a question close to my heart, because that's something we deal with very closely in our LVAD and transplant clinic every day. Yes, patients with obesity can receive heart transplants and still benefit from them. Now, let's keep in mind, obesity is, by definition for Europe, it's a BMI of 30 or higher. Nevertheless, the ISHLT recommends to consider a BMI of 35 as a relative contraindication for heart transplantation because it has been associated with worse outcomes after transplant. And unfortunately, we see this. Now, this does not mean that we should neglect these patients. By no means. But these patients need special care and they need our help. We cannot just refer them to a weight loss program and wait for them to be treated 6 months later. These patients need intensive, highly coordinated, high level of care so that they can be candidates for heart transplantation. And it's very challenging. And that's something that we are focusing in our program and that we think is going to make a big difference for these patients.
Dr. De Silva, fascinating topic. Thank you so much for joining me in this conversation today. And I just know there are going to be an ongoing number of new developments and new insights as to how we care for heart failure patients with obesity, given the prevalence of both of these. So thank you.
Thank you very much. It's a pleasure for me to be here. I'm very excited to chat with you about this topic, and I hope that we continue helping our patients overcome these two major pandemics.